Good afternoon. Thanks everyone for joining us today in this series webinar. I would like to take a few minutes to talk with you about the 2020 Diabetes Training Academy and the upcoming events. We're going to continue our monthly webinar. The next one is going to be on July 24th, where Dr. Valenki is going to talk about discuss the pharmacological therapy for patients with type 2 diabetes. Also, remember that we provide diabetes courses for support staff during this situation that we are right now. Is going to be virtual. The next one is going to be Friday, September the 13th. It's going to be 3-hour long courses for 2 days. So it's going to be Friday, September the 13th and Friday, December the 5th. If you want more information, I can send you an email or you can send me an email about it, but it's in our website. The other course that we provide is diabetes education course for people that want to become diabetes educator. Remember that that was a 3-day course in person, but now we're going to do it virtually. So it's going to be a new form that is going to be a month-long course where we're going to distribute the 22 lectures throughout this month, and then we're going to meet once or twice a week to discuss the classes, and we're going to have live classes, and we're going to have case studies, and we're going to do some work together every week. That's going to be, the next one's going to be August 2020, and then November 2020. So that information I can provide for you if you're interested in the courses. Also is in our website, but I will send you an email with all that information. Today, Dr. Pasquel will discuss the standard of medical care in diabetes in 2020. Dr. Francisco Pasquel is an assistant professor of medicine in the Division of Endocrinology at Emory University. So thank you, everybody. Thank you, Dr. Pasquel, for doing this webinar. And thank you, everybody. Please enjoy. You're on mute, Dr. Pasquel.
On mute.
Yeah.
There you go. Thank you, Ina. So today we're going to discuss standards of diabetes care in 2020. I'll try to give you a few of the updates that we have from the recent diabetes meeting from ADA. So this is the agenda. First of all, just give a brief overview of type 1 and type 2 diabetes as a background, and why I will be covering some of the topics. We'll discuss about general treatment goals. The lecture is going to be mainly focused on glycemic control, for the management of patients with diabetes. There's several different aspects that we need to take into consideration, but we will focus a little bit more on glycemic control today. I will discuss some changes to existing guidelines and review a few results from the American Diabetes Association meeting. And finally, very briefly discuss about transformations in care during COVID-19. I know this lecture was already covered in the previous webinar, so I will be very brief, but just share a few of our recent experiences. So as you all know, type 1 diabetes is the result of in general an autoimmune destruction of the beta cell in the pancreas that leads to an absolute insulin deficiency. That's why patients with type 1 diabetes are insulin dependent, and if they do not have insulin, they essentially have an increased risk of developing metabolic acidosis because of the buildup of ketones. So DKA occurs in patients with type 1 diabetes that are not taking their insulin. Patients with type 1 diabetes are very sensitive to insulin in many cases, and have a lot of variations in glucose levels. So they have a lot of glycemic variability. So glucose can go easily from 40 to 400 and back. And because of that sensitivity, they're also at risk for hypoglycemia, and they're obviously being treated with insulin, which is a drug that causes hypoglycemia in a large proportion of patients. And to manage patients with type 1 diabetes, we obviously monitor their glucose with point of care testing, and more recently with continuous glucose monitors. And they need to take insulin injections. And that type of therapy that we've been doing for several years and decades is starting to change for patients with type 1 diabetes. In the last few years, we've been learning more and more about the artificial pancreas, so hybrid closed loop systems, and we have continuous glucose sensors that are communicating with these pumps, and we're going into a world of automated insulin delivery. And the first closed loop to be approved was the Medtronic, and more recently Tandem had also their closed loop approved, and probably in the near future we will have another closed loop system with Omnipod. And I'll review very briefly some of those technologies based on recent results. So that's the care of type 1. So in type 2 diabetes, we also have insulin deficiency, but it's an impaired amount of insulin to overcome the insulin resistance that occurs in patients with type 2 diabetes. So there's not enough insulin to overcome that resistance, and when the pancreas gets tired and cannot produce enough insulin, hyperglycemia develops. Patients with type 2 diabetes are much less likely to develop DKA, but that can occur during severe infections, such as COVID-19. Patients with type 2 diabetes may also have an increase in glucagon secretion, such as that ratio between insulin and glucagon changes, and that leads to hyperglycemia. That is much more pronounced in patients with type 1. That's why they develop DKA. But as you know, there's other components in patients with type 2 diabetes that lead to hyperglycemia, including increased hepatic glucose production. We also have a reduction in the uptake. That's where glucose is supposed to go. Mainly is to the muscle. The excess of glucose that we don't use is stored in the liver, and the rest becomes fat. But obviously, the postprandial glucose depends on that uptake in the muscle. And in the patient with type 2 diabetes, there's defects at the post-receptor level in the signaling of insulin that is affected in type 2 diabetes. But we have learned in the last several years that there are several other organs that are affected in patients with type 2 diabetes. We know that they also have a reduction in the response of the incretin system in the gut. Incretins are hormones that such as GLP-1 that go to the beta cell, increase insulin production in the presence of glucose, decrease glucagon excretion, go to the brain to increase satiety. So that's affected in patients with type 2 diabetes. We have increased lipolysis associated with insulin resistance, and we've learned that the adipocyte is this endocrine system producing a lot of adipocytokines associated with insulin resistance. We have also learned that the threshold for glycosuria is changed in patients with diabetes. They have more reabsorption of glucose. And we have also learned that there's a dysfunction in the balance of neurotransmitters in the brain, including dopamine pathways. And as you can imagine, there's several different strategies. You're probably familiar with most of the different therapeutic options that we have for patients with type 2 diabetes. So we have medications that increasing the incretin effect, such as DPP-4 inhibitors, increasing the levels of those hormones, or we actually have agonists of those hormones like GLP-1 receptor analogs. The other important incretin is GIP, and there's research coming out of dual agonists of GLP-1 and GIP, and they're very potent medications, and they associated with an added benefit that is weight loss. Obviously, as you know, metformin continues to be one of the mainstays of therapy in patients with type 2 diabetes. It works mainly in the liver, decreasing gluconeogenesis. Recent data tells us that there's also significant effect in the gut. It has a minor effect in increasing glucose uptake in the muscle. And then we have the Sglt2 inhibitors, this new class that inhibits and blocks this sodium glucose transporter and the proximal tubule, changing the threshold for glucose reabsorption. This leads to increased glycosuria, and the patients lose calories so they can lose some weight. But these medications has become an incredible option to treat patients with heart failure, as I'll show a couple of slides about it. So again, for patients with type 2 diabetes, we mostly use pills, and when they fail, we tend to move towards injectables. But in recent years, there's recommendations to actually start earlier with some of the injectables, such as GLP-1 receptor analogs for patients with cardiovascular risk. So we will cover some of the newer guidelines on how to approach the management. So what have been, in summary, the advances in diabetes treatment during the last several years? One is in type 1 diabetes. The advancement in diabetes technology has been just incredible, and is making huge changes in how patients with type 1 diabetes are achieving glycemic targets, with a reduction in the risk of hypoglycemia. For patients with type 2 diabetes, these new medications, such as GLP-1 receptor analogs and the inhibitors of Sglt2 transporters, are changing our approach of management, because we have realized that those agents have actually cardiorenal protective properties. And we have also learned about metabolic surgery and how patients are going into remission many times, or decreasing significantly the amount of medications that they use. I will focus mostly on technology and non-insulin agents, which have been the advances in the last couple of years. So the changes in the ADA standards of care, if we look at there's a yearly publication from the American Diabetes Association every January that summarizes all the recommendations to care for patients with diabetes. That is, it's open access. You can even download the slides from ADA. And more recently, ADA and Diabetes Care have been publishing updates throughout the year, because science is advancing so quickly that sometimes the new recommendations change rapidly over time. So they're adjusting for that, and I think that's a great effort from ADA. So some of the major changes in the recent guidelines are, for example, the consensus on how we should interpret the data that we obtain from continuous glucose monitor devices. So there's recommendations on interpretation. There's recommendations on diabetes technology, and more data on automated insulin delivery. And probably one that affects the largest population of patients with type 2 is the changes in how we approach patients with cardiovascular risk, such as patients with ASCVD, those that have a predominance of atherosclerosis, also patients with diabetic kidney disease, particularly those with proteinuria, and patients with heart failure, particularly those with a reduced ejection fraction. So the glycemic targets have not changed majorly in the last few years. The recommendation continues to be to perform A1C testing, and this should be done at least twice a year for most patients, more frequently for those with unstable control. We continue to do point of care testing for A1C. It's an opportunity to make it more practical. The technology has advanced, and the A1C tests are becoming more reliable. And A1C can also tell us about the average glucose levels that our patients have. This table is just showing the estimated A1C that we can obtain when we don't have an A1C. If we look at glucose levels, we can kind of extrapolate the A1C that should be consistent with that level, and vice versa. So for every 30-point change in average glucose level, A1C tends to change by about 1%. So 150 to 180 to 10 to 240, etc. And one of the recent changes to the standards of care is that the ambulatory glucose profile is becoming standardized, and this is a very helpful printout that we can get from the different platforms that are used to obtain the glucose levels from CGM devices, and give us a very nice summary of glycemic control in our patients. And the information that it includes will include the time in range, which is now a major target goal for patients with type 1 diabetes, and it's being used also in clinical trials. And also now there's considerations about the time that patients should ideally spend below certain targets. So hopefully minimizing or decreasing the amount of time that patients spend in glucose levels less than 70 or less than 54, and at the same time decreasing the amount of time that patients spend in glucose targets above 180 or above 250. And this is the typical output. It has been simplified over time. It's easier to read. And if you look at this type of report, it will tell you a lot of very helpful information. It will tell you for how long the patient has been using the CGM, so for how long the CGM is active. And then it will tell you the time that the patient has been in the target range, which is between 70 and 180, and the goal is to keep that target above 70% of the time. And the goal is also to reduce the amount of time that patients spend below 70%, so less than 4% is the target, and less than 1% of the time below 54. Also, the goal is to spend the lowest amount of time possible above those target ranges, as you see here. The report will give you also an average glucose for the patient, and this glucose management indicator, which is kind of like a pseudo A1C that is derived from these readings. The output, this report, will also give you glycemic variability, which is telling you based on the coefficient of variation, how much those glucose levels are varying throughout the day. And the target goal is less than 36%. So this is the figure that comes with that output that tells you for this patient, for example, the patient spent 47% of the time in the target range of 70 to 180 and spend a large proportion of time above target. And this patient also had a large proportion of time. This should be ideally less than 1%, and the patient spent about 6% with glucose levels less than 54. So really not an ideal control for this particular example. So the goals continue to be for A1C of less than 7%. We could consider less than 6.5 when we can achieve this without hypoglycemia. So the main competing forces in the management of diabetes is avoiding hyperglycemia, but at the same time we want to avoid, as we intensify therapy, the increased risk of hypoglycemia that we have, especially with insulin and in patients with type 2 with insulin and sulfonylureas. For patients that are at the very high risk of hypoglycemia or have a limited life expectancy, sometimes a goal of 7.5 or even 8% may be indicated. Previously, we were thinking about those with increased cardiovascular risk, that they should have higher targets because of the results of large studies such as ACCORD that showed when we are extremely aggressive in targeting A1Cs, below 6.5 or below 6 in some of those studies, they may be an increased risk of complications. But those, at that time, we were not using the medications we have currently, and hopefully we will have more data, and some data from one of the studies with a GLP-1 receptor analog show that even using it in patients that have lower A1C levels, those medications are beneficial for patients with cardiovascular risk factors. So just to cover that part, how are cardiovascular outcomes trials change in practice? In 2008, FDA mandated that all new medications that are coming to the market for the treatment of patients with diabetes, there should be studies that prove that those medications do not increase the risk of cardiovascular disease. And this was mandated after analysis of studies with TCDs in 2007, where there was a suggestion that rosiglitazone increased the risk of heart attacks. That data was reanalyzed, and we learned that TCDs are associated with increased risk of heart failure because of volume retention, particularly more with rosiglitazone than pioglitazone. But since then, several large cardiovascular outcome trials have been published, basically to prove that these drugs are not increasing that risk. But these cardiovascular outcomes trials have actually showed some benefit in some groups of patients with cardiovascular risk. And we will discuss some of the results of those in the next couple of slides. So the medications that we have, the newer medications that are very frequently used, are DPP-4 inhibitors, GLP-1 receptor analogs, and inhibitors of Sglt2 transporters. So those are the newer medications. The older medications, as mentioned, we had metformin, we have TCDs, pioglitazone, and we have all sulfonylureas for several decades. But for the newer medications, for DPP-4 inhibitors, for example, those trials were powered to show that there was no inferiority in a primary outcome. And the primary outcome mandated by FDA is that composite outcome of major adverse cardiovascular events that includes cardiovascular death, non-fatal MI, and non-fatal stroke. So the primary outcome for studies with saxagliptin, alogliptin, sitagliptin, and linagliptin have been neutral, showing that these medications are safe in patients at high risk for cardiovascular disease. In one of the studies with saxagliptin, there was an increased risk for hospitalizations for heart failure. There was a numerical imbalance with alogliptin. Therefore, FDA put a communication out that for those drugs, we should be careful, particularly in patients with heart failure or patients with CKD. Those outcomes were not seen in very large studies with sitagliptin or linagliptin with several thousands of patients, where those medications seem to be safe. What about GLP-1 receptor analogs? So for several of these medications, they have actually shown a reduction in the primary outcome, the same MACE composite. So we had the initial study to show that benefit was a study called LEADER with liraglutide. This is GLP-1 receptor analog injected daily. And then this data was reproduced and sustained with semaglutide, also with albiglutide that they stopped producing, and with more recently with REWIND with dulaglutide. With exenatide, the upper limit of the confidence interval was at 1, so it was considered a neutral study. But if you see the results of the other, I think this was reproduced, and also that study showed a reduction in all-cause mortality, and all the estimates were below 1, consistent with what was seen with studies such as liraglutide. And a couple of them have shown also a reduction in strokes with semaglutide, for example, or with dulaglutide. And meta-analysis of these studies have been conducted and have shown a reduction with the use of GLP-1 receptor analogs for ischemic strokes. And the meta-analyses are helpful because the number of events in general for strokes in all studies was low as expected. There was no signal for hospitalizations for heart failure in any of those clinical trials. For the Sglt2 inhibitors, we've had studies with empagliflozin, empareg, with canagliflozin, we've had studies with dapagliflozin, and other with patients at high risk for kidney disease and Credence, where the MACE outcome was also assessed, and more recently presented at ADA this year with ertugliflozin, the Vertis trial. And what we have observed from this trial is that they consistently have reduced this composite MACE outcome with EMPA, CANA, and dapagliflozin. This was not seen in the recent trial with ertugliflozin. And when we look at the components of that MACE outcome, in general, the only one that showed a reduction in cardiovascular death was with empagliflozin. But the main effect of this class, as you can see below in the last line, is quite significant reduction in hospitalizations for heart failure. So when the studies have analyzed cardiovascular death or heart failure, there was a significant reduction, and this has been consistent, and this has been reproduced in real world data. Highlighted here is also non-fatal stroke. As you can see, no signal for any benefit with this group of medications, suggesting that there's not a major effect, at least in atherosclerosis in the central nervous system. And in addition to those benefits, so a reduction in a MACE composite outcome with GLP-1s, a significant reduction in hospitalizations for heart failure, and more recently, cardiovascular death confirmed in patients with and without diabetes in a large study with dapagliflozin. We have also learned that this class, the Sglt2 inhibitors, have also a significant impact on the progression of kidney disease in patients with diabetic kidney disease. So this was the first large trial designed to answer that question about the effect of these medications in patients with advanced diabetic kidney disease. In this study called the Credence Trial, the investigators enrolled patients with type 2 diabetes that had CKD, and at least 60% of that population had to have a GFR between 30 and 60, and they all had significant albuminuria, defined as an albumin creatinine ratio more than 300. And this is the primary composite outcome, including renal death, cardiovascular death, end-stage kidney disease, and doubling of serum creatinine. There was a significant reduction in the composite outcome, but as you can see in the other parts of this figure, B, C, and D, more dedicated renal outcomes, there was a consistent reduction in all of them. So quite significant impact. And more importantly, this study also reproduced the findings on patients with cardiovascular risk, so showing a reduction in the composite of cardiovascular death, MI, or stroke with a hazard ratio of 0.8, and also a reduction in hospitalizations for heart failure as seen in the other trials. And more recently, the study with dapagliflozin, the study called DAPA-CKD, was stopped early because of a significant impact of this medication and the reduction in the progression of kidney disease in high-risk people. So how have professional societies changed their recommendations? So we have in the United States, the main groups of guidelines come from the American Association of Clinical Endocrinologists and from the American Diabetes Association. So here on the right in this figure, you see the typical algorithm for glycemic control with a target of less than 6.5 for patients where we're not increasing the risk of hypoglycemia, and maybe an A1C target above 6.5 for those at very high risk of hypoglycemia. So this is the algorithm showing some preferences here in green for certain medications, but it brings the idea of starting dual or triple therapy in patients that are uncontrolled even from the beginning. So we have a patient that has an A1C level of 8 or 9%. It's not unreasonable to start with dual therapy from the beginning. We will be able to attain goals more quickly, and that will avoid the clinical inertia. In this figure, you can see that they're including the use of ongoing glucose monitoring with CGM preferred if available because of all the information that it's providing. We need to learn more about this benefit in patients with type 2. As you probably know, in patients taking oral medications, really the use of point of care didn't make much of a difference based on the monitor trial. But I think the information that we're obtaining from CGM and the information that the patients obtain from these devices, I think it's pretty it's very meaningful and may help change behaviors. I think there's probably less benefit in type 2 diabetes patients using the blinded CGM. So, but we need more research in that area. And for those patients with high A1C, the consideration for injectables should be there, especially insulin for those patients that are catabolic with significant weight loss. So here you can also see in this figure that independent of glycemic control, in those patients with established ASCVD, patients that have CKD or have heart failure with reduced ejection fraction, there's a recommendation to start a GLP-1 receptor analog or an Sglt2 inhibitor, not delineating specifically which kind of agent to use, but it has been included in that algorithm. The guidelines also provide some information on how to intensify therapy, either adding long-acting insulin for patients and how to do it. Here, for example, with the total daily dose calculated for patients based on A1C levels, and also the idea of adding injectables such as GLP-1 receptor analogs. But as you can imagine, the direction is not anymore unidirectional from metformin to more drugs to insulin, and that's where we stop. We actually are learning that we can add non-insulin agents to patients that are taking insulin, and they can benefit from that intensification of therapy. So over time, we've been learning how to individualize glycemic targets in our patients. There's considerations that ADA suggests based on the individual characteristics of patients. But the more we learn with the newer drugs without an increased risk of hypoglycemia, this is changing. And this is the algorithm proposed by ADA in collaboration with the EASD, the European Association for the Study of Diabetes. These are the guidelines on how to manage patients. So you see the first line is therapy with metformin, with comprehensive lifestyle for everybody. And then the next questions will be, are there any indicators of high risk of, or there's established ASCVD, CKD, or heart failure? If any of those is present, then we should maybe consider observing of which one is the type of cardiovascular disease that is predominant or kidney disease. So if we have a predominance of atherosclerotic disease, ASCVD predominating in these patients, or we have indicators of significant high risk, such as age more than 55 with coronary, carotid, or lower extremity artery stenosis, or LVH. So for those patients, maybe a GLP-1 receptor analog should be indicated. and an Sglt2 inhibitor could also be considered, but given some predominance to a GLP-1 receptor analog based on the results that I showed you. For patients that have a predominance of heart failure or CKD, and this is particularly for patients with reduced ejection fraction with a left ventricular ejection fraction less than 45%, or for patients with CKD with significant albuminuria, the recommendation is to prefer an inhibitor of SGLT2. So this is really what has changed dramatically in the management of patients with type 2 diabetes in the last couple of years. There's other considerations that will suggest this doesn't mean that we cannot use these medications in patients that do not have that, because this group of medications are also associated with weight loss. So if we're thinking about losing weight, which is a problem in a majority of patients with type 2 diabetes, either a GLP-1 receptor analog or an SGLT2 inhibitor could be beneficial. But something that is clearly important in the management of diabetes that we always should try to minimize hypoglycemia, therefore avoiding the use of insulin, also sulfonylureas if possible, given that we have other options. And however, when cost is a major issue, and unfortunately this is a problem not here in the US, this is a global problem. Sulfonylureas are effective medications, they're cheap, they're unfortunately associated with increased risk of hypoglycemia, and maybe some of them with increased risk of potential cardiac problems. But if used correctly and safely with good monitoring, we can use sulfonylureas and also TCVs, and we should remember that this is a good viable option to reduce cardiovascular risk. If we look at results of trials such as the Irish trial or Proactive with pioglitazone, we just have to be very careful about volume retention and avoid this medication in patients with heart failure. So this is how the landscape has changed in terms of the medications that we have available and how we should use them. So I wanted to cover a little bit of some highlights from ADA from the recent meeting. There's newer medications coming. I think one of the interesting one is the use of once weekly insulin. There's new closed loops that are being studied. There's the results of the Vertus trial that I showed you. And just of interest, I'll present a couple of slides on telehealth for healthcare delivery. So in terms of the newer insulin, this insulin is called icodec. It has this fatty diacid that binds to the molecule and that binds to albumin, and this binding allows a long half-life with a steady state. Once that you have a steady state, there's a continuous release of insulin from this albumin bound depot. So there's a lot of interest in the development of this type of insulin, because it could potentially help with adherence for patients. But obviously one of the main questions is, how is the safety of such insulin? So the results of the initial phase 2 randomized double-blind, double-dummy study were presented at ADA. Interestingly, this is a double-dummy, meaning that patients actually got 7 injections per week, which was via vial and syringe, or in an injection with a pen once a week. So the patients were blinded in the sense that we don't know what patients the patients didn't know what they were receiving. So I think it's a very interesting and a good design. Maybe not comfort is probably not the main goal of that study, but is actually looking at the efficacy and safety. So patients with A1Cs between 7 and 9.5 were randomized to icodec or glargine U100. All patients were on metformin, and they could or not be on a DPP-4 inhibitors, as you can see, using a long-acting insulin along with oral agents. So obviously not prandial insulin in this case, and not using sulfonylureas to minimize the risk of hypoglycemia. And these are the results for A1C or over time. the reduction from baseline, from a baseline A1C of 8.1 to 8, was down to 6.9, 6.7 between the two groups. Not statistically significant, but it tells you that this medication is efficacious. And then in terms of hypoglycemia, there were 53% versus 37% patients in the hypoglycemia alert value level 1. So this means less than 70. Clinically significant hypoglycemia, which is defined as less than 54. There were 16 versus 9.8%. This was a smaller trial, non-significant according to the presentation, but obviously you can see an absolute difference that I think we need to be careful and pay attention. But I think it's good to see that the risk of severe hypoglycemia was pretty low, and it's important to recognize that this was an aggressive protocol and treat to target protocol, aiming at very low fasting glucose levels. So I think there's a lot of interest in that medication. Then there's new data on hybrid closed loop system, and there's the advanced hybrid closed loop system that the results were presented, and this is basically adding this autobolus correction, targeting a glucose of 120. Well, so this is the Medtronic insulin pump that has this algorithm, and this new algorithm. The previous one, the initial one that was accepted, approved by FDA, is called the 670G. It is effective. There's some issues. A large proportion of patients going back to manual mode and not keeping the auto mode. But in this newer approach, they had different strategies to try to increase the proportion of time that patients stayed in auto mode. So that's one of the studies. It seemed to be effective, but I think the more interesting one is the one that actually compares the 670G with this advanced hybrid closed loop, which is the Medtronic that has this autobolus, and this was the first. I think this is the first head-to-head comparing two hybrid closed loop systems, and this was in adolescents and young adults with type 1 diabetes. And as I showed you, the outpatient, the glycemic report, the ambulatory glycemic report here in the upper right, showing that in this case, in red, we have the new closed loop system compared to 670G, and compared to baseline, we see an increase in the proportion of patients that have the glucose targets in range. We have a large proportion of them with the new system that are spent below 1%, so 90% of the time, 90% of the patients meeting that target. And also the combined outcome of more than 70% in target with less than 1% in hypoglycemia was superior for the new closed loop delivery system. Results of the Horizon were also presented. This is with Omnipod. This insulin pump does not have the tubing, is independent, and basically connects to a glucose monitor that gives information, and also significant improvement in this population. They have the option to have free choices for the targets, and when they chose a target of 110, you can see that the target range from 70 to 180 went up from 51% at baseline to 64 or 71% with the target of 110, with a low risk of hypoglycemia, with a significant reduction in the time spent above these targets, and additional measures, also significant improvement with a reduction in the coefficient of variation, this marker of glycemic variability. And in the real world, there was a poster with Tandem. Tandem is one of the closed loop systems that was approved recently last year. And this study looked at patients before 30 days before and 30 days after of patients that downloaded the algorithm and integrated that to their tandem. And they showed that there was a significant improvement in glycemic control, pre and post control in this real world data, an improvement in mean glucose from 160 to 148, proportion in range went up by about 10 points from 68 to 78%. The time spent below 70%, similar, but you can see the pre and post was consistent across different subgroups of patients treated with these medications. You can see pre and post here for patients with ages between 14 and 17, 18 to 64, and more than 65 year olds. And finally, from AD, I just wanted to present you this interesting data, but this is more in the world of implementation science. And this is the report from the implementation of this intensive telehealth intervention for rural patients with uncontrolled diabetes. As you know, we're all moving to telehealth because of COVID-19. So I thought this data may be of interest. This study was showing, or this report on the implementation is basically showing how the results of the pilot trial were implemented. So there was a pilot trial that was conducted years ago that showed that then a 6-month intervention with telehealth was associated with an improvement in 1.3 points of A1C compared to 0.3 to usual care with telehealth. So an estimated difference of 1 point percent with this intervention. There were 25 on each arm. And in that approach, basically they have a telehealth nurse that calls for 30 minutes. There's every Q2 weeks calls for 6 months, where they will review glucose data, medications, and also provide self-management support with following 8 modules. And this information is transferred and it's seen by a medical management team. In general, in this approach, they use this with pharmacists that will adjust the medications. So changes and recommendations without necessarily having interactions with patients. Actually, they didn't have that. They will provide the recommendations, and with that approach, they started implemented telehealth in several states, and they have data for the ones in green, and they have been implementing this with a clinical nurse and a PharmD that provides the changes, recommendations for patients. And they are analyzing that data with REAIM framework. Basically, they are assessing reach, effectiveness, adoption, implementation, and maintenance. And of interest in the effectiveness, they observed a reduction in 1.36 points in A1C. The reach is not big. It's actually a total of 125 patients were enrolled. I think there's a lot of room for improvement, but this shows us how they have implemented an approach that actually works, that was shown to works in significant results in the clinical trial, and they are now implemented in real world practice, and it seems to be working. The sustainability of that, I think it still needs to be evaluated, but they have been able to sustain a reduction in A1C of 1% after 18 months. So hopefully we will learn more about these approaches as they have more reach. And finally, I just wanted to cover some transformations in diabetes care. Obviously, this has been a disaster during COVID-19. We in the hospital where patients are going, we're seeing an increased risk of mortality. In the hospital, we will try to get to our goal of 140 to 180. We use insulin for patients in the ICU, for critically ill, for those with DKA. We use subcutaneous insulin on the floors. We obviously need to have hypoglycemia protocols guided by point of care testing, and there has been some consideration of the use of non-insulin agents. So those are the typical recommendations in the hospital. But with COVID-19, we've seen that there has been a need for a response to try to decrease the waste of PPE, decrease the risk of exposure of healthcare workers. So we have proposed an approach to have a response and mitigate all those problems with inpatient response teams, changing protocols, and that's what we have been observing that is actually occurring naturally in several centers. In the non-critical ill patients, based on our previous experience, we have been using DPP-4 inhibitors for patients with mild, moderate hyperglycemia that are not taking high doses of insulin at home, and this approach seems to work. We have adapted our recommendations to considerations based on COVID-19. This was published recently, but I think the main area where transformations are occurring is for those patients that are requiring multiple point of care testing, multiple interactions with nurses and patients, wasting PPE and increasing the risk of exposure. So based on the results of a previous study by Dr. Pancreas at Emory, showing that we can actually use subcutaneous insulin in patients with DKA. Several centers have adapted their protocols. This study showed that there was a you can see the overlap of all these curves with the treatment of IV insulin versus subQ insulin, significant improvement in DKA and acidosis and glucose control with all the approaches with subQ. There's studies with Q4 hours as well. So we have developed a web page. I can show you 1 second if this opens. So in this effort, we have been collecting all the transformations in care that are occurring in patients for the care of patients with diabetes during COVID-19. I'll invite you to visit this page. You can share their experiences if you have been changing the ways you practice care for these patients. So we want to learn how other people is changing their care for patients with COVID-19. We'd have suggestions on ways to implement CGM, and this is an example of the protocols that people are modifying. So you have those available if you want to implement such protocols in your hospitals. And there's not only transformations in the management of DKA, there's changes in how we monitor glucose in the hospital. FDA was not opposed to the use of CGM in the hospital. Therefore, companies such as Dexcom and Abbott have been helping the hospital systems to use continuous glucose monitoring, because the technology now allows not to just obtain continuous glucose measures, it actually allows to see those glucose values remotely. So the sensors are being applied to the skin of the patients are being prone, so they're many times placed in the arm, and the nurse, as long as the nurse is 20 feet from the patient, she can obtain those readings and record in the chart. So we're looking for ways on how to implement. FDA also gave the okay for patients to bring their own home meters because of the same reason for decreasing exposure. We put recently some recommendations on how to implement continuous glucose monitoring in the hospital. This was published a couple of years ago. You can access to that publication in our webpage. And basically what we try to put together is some ideas on how to do it, and some considerations that are important with the two glucose sensors that do not require calibration. We focused on this too because there's no need to confirm the glucose values with point of care testing periodically. There may be some issues at some points with the sensor where we have to do it, but in general that is not required. There's some considerations that are there. And more recently, we've been collaborating with Ohio State University on how to implement this in the critical care. That's the setting where we have the least information, And this is off-label, but has been FDA has not objected to this, and several centers are trying to do this in the ICUs because that's exactly the place where it's the most needed. So you can have also this information of how to implement that in our page. There are several other protocols that can be accessed. So in summary, for this talk, I will say that I think the major changes that have occurred in practice in the last few years is this important idea of risk stratifying our patients according to their cardiovascular or renal risk, and using the results from the large clinical trials to try to improve outcomes in those patients, not to only improve glucose control, but also to decrease weight and delay the progression of kidney disease, and reduce the hospitalizations for heart failure, and hopefully also reducing ischemic events in patients with ASCVD. We have learned about glucose monitoring and new target goals that are being analyzed in clinical trials. We've learned about we're learning about automated insulin delivery with new closed loop systems. I think in the near future, I think those are going to be probably approved in the near future. So we will have patients coming in to your practice with insulin pumps and closed loop systems. Hopefully the access is going to allow more patients to get this technology as it continues to show that it improves outcomes. There's interest in the weekly insulin. We obviously are expecting to learn more about the best practices for managing patients with diabetes with telehealth. And finally, during COVID-19, we're still at the observational data level or QI projects, and obviously there's a lot of more research that is needed. And I will end there, and just here to thank some of the collaborators in our team. And I think we have a few minutes for questions. If anybody has any questions, happy to answer.